It's day 3 here in Washington, D.C. at TCT. I'm here with Patrick Serruys, and I am Peter Block, and we're here for On the Scene. Patrick is a legend, doesn't need any introduction, and now has looked at a large trial of bioresorbable versus standard drug-eluting stenting. So Patrick, tell me about your trial.
So that trial is the first randomized trial, metal versus bioresorbable, eluting the same drug. Small trial, 501. The goal was really to show that this piece of plastic, because it's a piece of plastic, has the same mechanical performance than the metal. That was the primary goal, and I think we demonstrate that by angiography and IVUS. Certainly the operator were a little bit more prudent with the plastic than in the metal, so they use a little bit less pressure and a small balloon, but mechanically the result was good. And the other things we have done in this trial is look at angina by using the Seattle angina questionnaire during exercise testing. All things were equivalent in both groups, so really the polymer sustained the comparison with the metal. The only puzzle things that we discover is that during that trial, looking at the regular basis to the adverse event, we realized that there was more angina site reported by the investigator. And that's something which was very puzzling for me. So I spent a lot of time to see what are the consequences of that in terms of change of medication, reintervention, diagnostic tool, and so. But I think it's a real phenomenon, and we have to figure out why in the upcoming trials.
So the increase in angina came in the bioresorbable group, didn't it?
There was less angina in the bioresorbable group and more angina in the metallic group.
Okay, so I had it wrong when I asked the question.
Yeah,
okay, so good. So it seems that the bioresorbable group is the better of those two groups concerning.
There is something which is beneficial for the patient. It might be a better conformability of the polymer. It might be the vasomotion which come back. It can be something technical we call a mismatch compliance. It's three potential factors and many others who makes the fact that the patient are reporting, the patient receiving the absorb are reporting less angina in their daily life.
There was some talk also about whether there's downstream effect of the drug-eluting stent, which causes a change in vasomotor activity in the small vessels. That's, I guess, also a possibility. Would you agree?
So the microcirculation is certainly a big topic. Right now we are looking with ammonia and PET if there is a real effect on increase in flow after the biodegradable. Don't forget that it is eluting lactic, which is getting metabolized by the mitochondria in the cycle of Krebs. So there is many things that we don't know about it.
Okay, so let me ask you the obvious question, Patrick. If you needed a stent in the mid-right coronary artery, would you want a bioresorbable one at this point in time?
Yes, for me the answer is quite clear. You know, many times at big American meeting I make a prediction. I mean, in '94 I said publicly I think that by year 2000 there will be stent everywhere and no more balloon. There was a murmur of disbelief, but that was the case. I think in 2000 at the European Society I said drug-eluting stent are there for the next 15 years. I think that before the end of this decade, 2020, metal will be the minority.
My advice is not to mess with Dr. Serruys' predictions. Thank you, Patrick. It looks like these two stents are at least equivalent for now, and the bioresorbable stent certainly has life.
It's still a long way, but there's a lot of room for improvement. So for a first generation, a first randomized trial, I'm very pleased.
And Patrick says it is here to stay.